This program is about the patient with decreased mobility. After completing this lesson, you will be able to identify two groups of patients who are vulnerable to the problems of decreased mobility, define 3 principles of range of motion exercises, describe 2 ways to prevent constipation, and explain 3 points of care for the incontinent patient.
There are only 24 hours in a day, and it seems that time does fly. And so do many people as they go about their everyday lives. For the active person, there just doesn't seem to be enough hours in the day. From the moment the alarm sounds, it seems we are constantly on the go, exercising, attending school and work, socializing, and planning for the future. We eat, shop, clean, and do laundry. We are in control of our lives because we are active. Sometimes we take that physical mobility for granted. Being active and able to move about and function independently are basic elements of physical and psychological well-being. At the end of a long day as we climb the stairs, we look forward to sleep because we have earned it. But for the person with decreased mobility, life can be much different. Every one of the 86,400 seconds in the day can seem like an hour when your world is defined by the limits of your bedroom. Because mobility is an essential element in controlling one's life, the person with decreased mobility cannot take charge and is often dependent on others for simple daily needs. And that lack of mobility can lead to more problems. Decreased mobility, whether minimal or severe, can affect the normal function of every system in the body. What happens to these people? Why does a person lose the ability to be up, about, and active? There are many reasons. Almost anyone can experience a temporary decrease in mobility because of an injury, an illness, or a surgical procedure. The 24-hour flu has confined even the most famous of individuals to bed, making them dependent on others. But this is a temporary situation, and before long, the person is up and active again. You may never care for someone who is temporarily immobilized, so to speak. However, if you do, remember that this person can experience some of the same harmful effects we will discuss in this program. Be sure to appropriately modify their care. Persons who are chronically ill lose mobility. New medications and modern medical and surgical procedures help many people survive diseases, such as diabetes and cancer, which were once synonymous with death. The person must live with the disease because there is no cure. The disease causes permanent changes and damage to the body, limiting mobility and activity. Some of the most prevalent chronic illnesses are heart failure and heart disease, cerebrovascular disease, angina, chronic obstructive pulmonary disease, arthritis, hypertension, and diabetes. Chronic disease can lead to disability. A disability goes one step further than a disease in that the person is more limited and less able to perform major activities. About 33 million people in the United States have disabilities which interfere with daily activities. More than 9 million disabled individuals cannot work, attend school, or maintain a household. The major causes of disability are chronic conditions, such as arthritis, back conditions, heart disease, and impairments to the lower extremities, amputations, paraplegia, or hemiplegia. A disabling disease does not discriminate by age. For persons under 18, the major causes of disability are asthma, mental retardation and illness, speech impairments, deafness, and ear disease. And the last group of individuals who experience decreased mobility is the elderly. The normal processes of aging tend to slow a person down and limit activity. The losses that accompany the aging process, such as the loss of a job to retirement, promote a sedentary lifestyle. And age-related changes make the elderly person more vulnerable to chronic illness, which further restricts and limits activity and mobility. Over 87% of those 65 and older suffer from 2 or more chronic diseases. If you stop and think a minute, you will soon realize that the majority of the patients you care for experience decreased mobility. Because they are elderly or disabled or suffer from a chronic disease, they are limited in their activity and are dependent on others for some or all of their needs. Decreased mobility, in turn, puts the patient at greater risk for problems that are related to the lack of activity. Putting all of these factors together, the elderly, chronically ill, and disabled patients are really in jeopardy. We can illustrate this with a simple equation. Start with the normal processes of aging and the problems of chronic illness. Add the risk factors of decreased mobility, and the result? More problems for the patient. That is why this program is dedicated to all those patients with decreased mobility, and to you, the caregiver. We will discuss some of the risks of decreased mobility, the problems they present, why the elderly or chronically ill patients are more vulnerable to these dangers, and what you, as the caregiver, can do to prevent or minimize those problems, while helping your patient to enjoy the best quality of life possible. We thank you for taking the time to learn more about the special needs of your patient. There are 3 broad goals of care delivery for the patient with decreased mobility. As caregivers, we must help the patient to manage the existing illness. You do that as you follow the care plan for the patient's specific disease or condition. Then we must work on improving function and preventing complications. There are strategies you can incorporate into your everyday care delivery to assist your patients to function at their optimal levels, in spite of their limitations. Your ability to assist your patients depends on an understanding of the impact of decreased mobility. We will use a hexagon as our model to guide our discussion. That model will also show how everything is tied together. Each time the second hand on a clock ticks, it affects the time. Likewise, changes in one component of the hexagon can impact on others, like a ripple effect. A decrease in mobility directly influences 6 essential components of a person's daily life: activity, elimination, cardiac and respiratory function, nutrition, skin, and self. With this model, you will quickly see what we mean and what you can do to help your patient. First, let's meet Mary. Mary was diagnosed with multiple sclerosis in 1959. She knows what it is like to lose mobility, but she manages to stay in control of her life. Mary, along with Anne, her caregiver, will share their insights, hints, and secrets, so we can benefit from this first-hand knowledge as we learn about the challenges and problems of decreased mobility. It seems every time we turn on the television or read the newspaper, we learn more about the benefits of activity and exercise, and its influence on other parts of our life. There is a statistical link between exercise and cardiovascular health. Muscles, joints, and bones become stronger. Exercise enhances our well-being, helps control weight, and relieves stress. Exercise can even delay some of the effects of aging. But changes related to aging and disease interfere with activity. In aging, there is a gradual loss of muscle strength and endurance, reduced flexibility, and increased stiffness. These normal changes make it difficult for the elderly person to be active. Because of joint pain, muscle weakness, respiratory distress, fatigue, balance or coordination problems, just about every chronic disease decreases performance and limits activity. A chronic illness can sap a person's energy or affect a part of the body which is essential for activity. Hippocrates once said, "All parts of the body which have a function, if used in moderation and exercised in labors to which each is accustomed, becomes thereby well developed and age slowly. But if unused and left idle, they become liable to disease, defective in growth, and age quickly. Decreased mobility results in more weakness and joint stiffness, less flexibility, and wasting away of muscle and tissues, making it even more difficult to move. And other parts of the body, the bowel and bladder, cardiac and respiratory systems, nutrition, skin, and self all suffer. But there is hope. You can assist your patient to increase activity and exercise, which will help overcome the negative effects of decreased mobility. A patient recuperating from a total hip replacement or a heart attack will have a structured exercise program approved by the physician and coordinated by the therapist or nurse. This program is designed to restore or maintain function. For many patients with multiple sclerosis, Parkinson's disease, or similar conditions, an organized program helps them prevent contractures, maintain joint flexibility and strength with less rigidity and spasms, benefits which facilitate transfers and ambulation. Mary has a home exercise program.
And starts by stretching my legs, stretch my legs, loosen them up a little bit, and then I work on the rotations. I usually do 100, show with the way you support my leg. My lesser leg, I do 100 like this. And then take your hand off my leg. I do 30 myself, which requires more effort on my part.
Be sure that you follow the home therapy program and care plan, which provides direction for each patient. Another program which will benefit many of your patients is range of motion exercises. Each joint of the body has a normal range of motion. That is the amount and type of motion it can do. This range varies from person to person and is affected by physical condition, genetic makeup, age, and disease condition. We do range of motion exercises continually throughout the day, bathing and dressing, walking, stretching, as we reach for something in the cupboard. However, your patient has less opportunity and is limited in function because of age or disease. So there can be a wide variation in the degrees of motion from patient to patient. If your patient has limited mobility because of a chronic illness or disability, range of motion exercises are essential. These exercises are designed to maintain the motion of joints and strengthen muscles. This helps preserve function and prevent deterioration and deforming changes. Maintaining the patient's range of motion makes it easier to transfer, move, and care for that patient. As a part of your basic training, you were instructed in range of motion exercises. There are two types, passive and active. Passive range of motion is performed by another person when the patient is unable to move the joint through its range. Here is just a quick review of the principles for passive range of motion exercises. Support the joint you are exercising. Move only one joint at a time, slowly, smoothly, and gently through the exercise. Exercise both sides of the body, unless your care plan indicates otherwise. Don't force a joint beyond its range of motion. These exercises should not cause pain. We will join Jean, a physical therapist, as she performs passive range of motion exercises for Gladys, who has a history of a stroke with left hemiparesis or weakness. This demonstration will highlight the basic exercises and is not meant to take the place of your assignment, training, or policy and procedure.
It's important to support the joint that you're moving so that you're only moving one joint at a time. In other words, when I'm going to be moving her fingers, I don't want her wrist to be bending at the same time. So to keep her wrist stable, I'm going to take a nice wide grip around her wrist and then place my fingers over her fingers and curl them so that her fingers are bending, and then come on the inside and gently open them so the fingers are open. And curl and open. When you open, the fingers come from the bottom up. With the thumb, again, I'll stabilize the wrist and bring the thumb across the palm, hold it there for a little while, and then bring it away from the palm. Many times with a patient who has had a stroke, the hand and the whole arm becomes quite tight or has the potential of becoming quite tight. So these exercises can prevent that from happening. With the wrist, I'm going to hold at her hand and at the opposite side of the wrist. So again, just one joint is moving. And here I'll bring her hand back and forth in somewhat of a waving motion. So we go nice and slow. Another exercise for the arm is for joints in the wrist and the elbow. For this one, I'm holding her wrist steady and just turning her forearm so that the palm of her hand is facing up and then it's facing down. You can keep the same hand hold positions for range of motion at the elbow. Here, I want to bring the arm down so that her elbow is as straight as it will go, and then with the thumb leading the motion, bring her hand up toward the shoulder. So the elbow is bending and straightening. To do passive range of motion at the shoulder, it's especially important not to go past the point of pain. If someone has had a stiff shoulder for a long time, or if they've had a stroke where the muscles aren't working as they should to hold the joint in the right position, it's pretty easy to cause pain at the shoulder. Here I'll hold her wrist, I'll support under her elbow, and bring her arm up about halfway like this. See how it feels? Is that all right? If it feels okay, you can go up and back a little bit more. Bring it a little bit out to the side like this, and in this, as with the elbow range of motion, the arm is positioned so that the thumb leads the motion. Another shoulder range of motion exercise involves bringing the arm across the body to the opposite shoulder. My hand holds are the same, except I switched arms, make it a little bit more comfortable for me. Holding onto her wrist, supporting her elbow, we'll go across to the opposite shoulder and then out to the side. Trying to straighten the elbow out here, and then it's bending and reaching across like that. It's hard to exercise the back, but I think it's real important. People tend to get quite stiff when they're not moving normally, and it's also a comfort measure to do this next exercise. Most people say that it feels good on their back. It's a little bit of a stretch. So for this one, I'm going to help to bring her knee up on the left. So I'm just going to bend your knee so that your foot is on the bed. Now if you could bend this knee so that they match. And what we're going to do here is just slowly bring your knees from one side to the other, and this will stretch a little bit at your hips and some in your low back. So that usually feels pretty good. You will probably need to keep the person's foot stabilized on the bed, because if it is paralyzed or very weak, it won't stay up here by itself. So I'm holding just with the web space of my finger of my hand so that it's comfortable across the top of her foot. What we're going to do here is let your knees come over to me. Let your knees come over the other way. And at first, they might be pretty stiff, but as you increase the repetitions, the muscles will stretch out, and you'll find that the knees will go a little more in each direction. I'll start with an exercise that's similar to the one that we just did for the back. This time I'm going to bring your knee side to side again, and this is for the muscles at the hip. Just go bring the knee in and the knee out. Another motion at the hip that we want to do is flexion or bending. To do this, I'm going to hold on to Gladys's heel and support her knee under the knee. And then I'm going to slowly bring your knee towards your chest and then slowly bring it back down to the bed. So I'm trying to move my body when I'm moving her legs so that it's a lot easier for me as well. Another exercise at the hip is bringing the legs side to side. You support under the heel and under the knee, and you want to keep the leg about level with the bed. And with this one, I'm just going to bring your leg out to the side a little bit and then back to the middle. So slide it out toward me and back in. It isn't necessary to go way out to the side. Just about this far is fine. If you feel tightness when you get to this point, then stop. But if you don't, you want to take it out about this far, that's good. When you do this stretch, you can cup their heel in your hand and then use your forearm against the ball of the foot to push on the ball of the foot, pull the foot up like that. You want to hold it for a good 15 to 20 seconds and use your body weight, because that way you can hold it and you won't get tired. So with this one, you're going to feel a little bit of a pulling in the back of your leg. So if it feels like that, it's okay. If it hurts, then you need to tell me. And one last thing at the foot. And that's turning the foot so that the outside border is up like this, and then we'll turn it the other way so it's coming up to the middle.
The second type of range of motion exercises is active range of motion. The patient is able to move the joint and performs these exercises. Your role is to provide verbal instructions and encouragement. At the beginning of each session, encourage your patient to exercise the head and neck muscles. To do this, instruct your patient to look to the right, down at the floor, and to the left, slowly and carefully turning the head. We will join Jean and Gladys in progress as they demonstrate active range of motion exercises for Gladys's right side.
So we'll start with the hand, with opening and closing. You want to use your right hand and open them up, and then make a fist, a real tight fist, and get your thumb in there too. Stretch your fingers open, make a fist. Okay. The next is the wrist, so you make a waving motion, nice and slow. If someone has a problem with their shoulder or their arm tires easily, have their hands supported on a tabletop or something when they're doing their hand and wrist exercise. The next one is palm up, palm down. And then for the elbow, stretch your arm out to the side and then touch your shoulder. All the way down. And then the shoulder, active range of motion. We'll do the two similar to the passive. Try and bring your arm up over your head. And here you don't have to be so careful about going too far because the patient will limit themselves. They'll just go as far as they can under their own strength. And then the other one is coming up and across to your other shoulder. Touch your shoulder down to your side. Good. So that's active range of motion for all the joints in the arm. To work on the muscles that flex or bend the hip, what I'd like you to do, Gladys, is just to slide your heel along the bed and pull your knee up, let your leg bend, and then slide it back down.
That hurts the knee.
So we'll just go as far as what's comfortable. Okay? Now I'd like you to do that by yourself. Slide it up, slide it down. That's great. The next one for the hip muscles, I'm going to help this leg so that it stays supported like this with the foot on the bed. And what I'd like you to do is to keep your knee real stiff and then slide your leg out to the side and back in. You can do that about 3 times. Try to keep your knee nice and straight. This works on the muscles at the hip and the muscle in the thigh that's real important for standing and walking. The next exercise is mostly to work on the same thigh muscle. What I've done is rolled up a bath towel to act as a support under her knees. So pull your knee up and I'll place this under your thigh. And then the exercise is to lift your heel up off the bed and hold your knee straight and then bring your leg back down. It's like a kicking motion. Lift your heel up and then back down. So try that by yourself. Okay, that's fine. Then the last one, the ankle joint, is pumping your foot up and down like you're stepping on the gas in the car. So you point your foot down and pull it back.
I'm not moving.
You're doing fine. This one's good to keep the ankle flexibility normal, and it's also good to help circulate the blood in the lower leg.
If your patient is on an organized exercise program, or you are assigned to perform range of motion exercises, observe your patient's performance and tolerance. Document the type of exercises and how much the patient did, the patient's response, any complaints of pain, stiffness, spasms, muscle cramps, and other information as appropriate. Also report any significant decrease in the patient's range of motion or tolerance from one day to the next. For all of your patients, whether they have a structured exercise program or not, it is important to remember these points. Regular activity is important. Encourage the patient who can walk to ambulate regularly, from the kitchen to the bedroom, to get the mail, or even up and down steps. If your patient cannot walk, then sitting up is just as important. Encourage and assist the patient to do household duties, or participate in self-care or social activity within the limit of tolerance and ability. Regular changes in positioning enhance the functioning and comfort of all body parts. Some of your patients will be able to change positions without help, while others may need some assistance or depend totally on you. Assist your patient to transfer to a chair or to turn regularly while lying in bed, at least every 1 to 2 hours. Because proper positioning and alignment affects mobility, Use pillows, footboards, splints, whatever, to assist your patient to maintain proper alignment. The patient should also avoid sitting in one position for prolonged periods of time. There may be other points in the treatment plan which are important for your patients. Assistive devices, such as a walker or cane, crutches, and braces, aid the patient's movement by relieving pain and reducing stress loads. And above all, be careful. Use safe techniques and good body mechanics when assisting the patient to move.
Oh yes, Anne had a very seriously back ailment when she was young, and she was very much afraid that she couldn't handle me. But she found that she uses her legs and her hips and not her back, and that she can transfer me very easily. But then she knows my limits, and I know hers. So we work together.
Encourage the patient to modify the environment so it is safe and functional. Mary's home has been adapted to accommodate her physical disabilities, maintain her safety, and promote her optimal level of performance. Adopt a concerned, watchful attitude to prevent accidents.
Don't take any risks. I can be sitting in my chair and the doorbell rings, and of course there's no one to answer it because I'm home alone. And I just think, well, they can come back again.
We'll take some time now to review this information. What can cause decreased mobility? What is a chronic illness? Can you list some benefits of activity and exercise for your patients? What is the purpose of range of motion exercises? Can you describe the two types of range of motion exercises? Many patients devote considerable time and attention to the function of the bowel and bladder. And as we move through this section, we'll see that problems in bowel and bladder function affect activity, nutrition, skin, and self-image. To do its job, the bowel needs a good diet, which includes fiber and plenty of liquids. It also depends on activity to aid the process of peristalsis. Peristalsis is the passage of waste through the intestinal tract. As a person ages, there is reduced muscular activity and slowed peristalsis. There are many factors which diminish the appetite, so the older person does not consume enough fiber or fluids. Many medications used to treat chronic diseases interfere with the function of the bowel. Add to these the lack of activity and exercise and the poor appetite that accompanies decreased mobility, and the result is a problem with constipation. Constipation is one of the most common themes of advertisements. It seems as though a new natural remedy is introduced every other day. Why does constipation create so much concern for so many people? Constipation is defined as a decrease in the frequency of stools, or difficulty in the formation or passage of stools. Constipation can result from inadequate fluid and fiber in the diet, changes in mealtime, impaired communication, and decreased activity. One's perception can also affect the problem. Many people believe that constipation is the inability to have a bowel movement every day, even though there is no sufficient medical evidence to support the need for daily bowel movements. Many chronically ill and elderly people suffer from habit constipation. It is their habit to not include enough fiber in the diet or drink enough fluids, and to ignore the urge to have a bowel movement. Many more overuse laxatives. Laxatives can flush vitamins and nutrients out of the system and cause excessive excretion of water, sodium, and potassium. Habitual use of laxatives tends to weaken muscles in the intestines, making them flabby and less able to function properly. When used improperly, laxatives do not cure constipation. Constipation will not only return, but it can be worse. Like the rhythmic beat of time, a regular pattern can help your patient prevent and treat constipation. Encourage increased fluid intake, up to 8 glasses a day as allowed. A regular meal pattern is essential. Plan and deliver a well-balanced diet with adequate sources of fiber. Fiber increases the weight of stool, making it easier to pass. Good sources of fiber include nuts, brans, whole grain breads and cereals, and raw fruits and vegetables. Regular exercise and activity also improve bowel function. Promote regular bowel movements by setting aside a specific time each day. Whenever possible and safe to do, assist the patient to use the toilet, or at least to be in a sitting position on a bedside commode. Provide time and privacy. For all of your patients, monitor bowel patterns. Record and report any signs and symptoms, such as pain, cramping, or blood in the stool. We must also talk about the bladder. The bladder undergoes several changes as a result of the aging process. Bladder capacity diminishes to 250 cc's from 500 to 600 cc's. The kidneys cannot concentrate urine as well, so the person experiences frequency and nocturia, which is frequency at night. The bladder and ureters tend to lose muscle tone, which result in incomplete emptying and residual urine sitting in the bladder. Chronic diseases such as multiple sclerosis, spinal cord injuries, and chronic infections can cause bladder disturbances with loss of sensation, distension, retention, overflow, and uncontrolled emptying. It is difficult for the patient with decreased mobility to get to the bathroom when the need exists, or to drink water when thirsty. Using the bedpan or urinal can be uncomfortable, inconvenient, and messy. The end result is problems with bladder infections and incontinence. Residual urine, which is retained in the bladder, can increase the incidence of bladder infections. Encourage increased fluids, up to 2,000 to 2,500 milliliters a day as permitted, particularly if your patient has a history of bladder infections. Check with your supervisor before increasing fluids. Water is the best liquid, but it helps to vary the types of fluids that you serve your patient. Coffee and orange juice in the morning, iced tea for a snack, diet soda in the afternoon, gradually increasing the amount of fluids. Monitor your patient's intake. Sometimes it is very difficult to keep tabs on the amount of water one drinks during the day. Was it 4 glasses or 8? To ease this dilemma, set aside in the refrigerator a measured amount of water in a special container each day. This water is just for your patient, and it's probably the best thing to drink between meals. Remind your patient to drink the water from this container. At the end of the day, the container should be empty, and the patient will know exactly how much water was taken in that day.
Regarding the bladder, as I used to say when I was walking, wear polyester pants. They dry quickly. Every once in a while, that bladder can't be depended upon.
Urinary incontinence is another situation you will encounter. Incontinence is the inability to control the passage of urine from the body. Up to 40% of the elderly population suffer from incontinence. Prostate enlargement in men, weakened pelvic muscles in women, illness, infection, confusion, medications, fatigue, and decreased mobility all contribute to incontinence. The person who is incontinent will restrict fluid and activity because of fear of an accident and suffer from embarrassment, odor, and possible skin breakdown. When your patient is incontinent, look for causes within the environment. Can the patient get to the bathroom easily? If the only bathroom is upstairs and the patient has difficulty climbing steps, the bathroom could just as well be in Alaska. Can the patient undo buttons and zippers on clothing? Then a routine will help. Your patient needs a good fluid intake, but set it up on a controlled schedule. Give measured amounts at set times, decreasing the amount of fluid in the evening to ease problems during the night. Set up a regular toileting schedule, using a toilet or commode whenever possible. Track your patient's episodes of incontinence. If they occur about every 2 hours, assist the patient to the bathroom every hour and a half. Provide good skin care. Thoroughly wash the skin, rinse completely, and pat dry as soon after an episode of incontinence as possible. Cleanse from front to back to avoid contamination. Put on clean undergarments. If possible, expose the skin to air, maintaining the patient's privacy and sense of dignity. Not only will good care protect the skin, but it will control odor. Again, there are important observations to note for all your patients. Note the color, clarity, and odor of the urine, reporting any changes in volume or characteristics. Report any complaints the patient may have, such as burning, pain, or a full feeling. Carefully inspect the skin regularly for any signs of irritation or breakdown.
Now, regarding the bowels, I've had some nasty accidents, very unnice accidents. And that really is devastating because when you have an accident with your bowel, it's bad, and especially if my husband has to handle it, that's not good. But again, I say I certainly didn't do it on purpose.
Some patients may also suffer from stool incontinence, which can result from the disease process or medications. Most often, stool incontinence is caused by a fecal impaction or gross constipation. The impaction does not totally obstruct the bowel, so stool can seep around the area of impaction. Monitor your patient's bowel habits closely, then set up a regular schedule. Implement measures to prevent constipation. Provide good skin care. Discuss the patient's situation with your supervisor. And remember, these episodes are embarrassing, devastating accidents, which would not occur if your patient had the choice. Be as tactful and caring as you can be. Your patient may benefit from incontinence briefs, which are available at most pharmacies and grocery stores. Be sure that these briefs are applied and disposed of properly. Provide good skin care in between changes. Be sensitive to your patient's situation. Never call them diapers. Activity, diet and fluids, skin care, and watchful observation will assist your patient to overcome the problems in elimination created by decreased mobility. Let's pause for a moment to review. What are some measures to prevent constipation? Why are fluids essential for the patient with decreased mobility? What are important points to remember when caring for an incontinent patient? How quickly we have run out of time, but we certainly have learned much. We have talked about the special needs of the patients who experience decreased mobility, particularly the elderly, chronically ill, and the disabled. We have looked at some of the unique problems they can experience because of decreased mobility, which affect exercise and elimination. And most importantly, we have presented helpful hints and techniques that you can use in your care delivery every day. But there is much more information, and we will discuss that in the second part of this program. So take the time to implement these strategies in everyday care delivery, and we'll see you soon.